Hello, everyone. Good evening. I'm Ruby Pavankar, the president of Apaaaci, and I would like to welcome you to this very first JAAFCA, that is Apaaci's flagship program. Leadership development is an important strategy for Apaaaci for making a robust future for the organization as well as for the specialty of allergy and clinical immunology in the region. JAAFCA, as you have seen, is Junior Apaaaci Leadership Forum and Cafe. It has three key elements in it. One is empowering the future younger generation for them to lead and to motivate, as well as to be curious and to excel, to share their vision and their experiences, and to interact with colleagues across the region and beyond. JAAFCA will provide this platform to create the future of allergy and clinical immunology in Asia Pacific. Today we have with us three key speakers. The first speaker is Dr. Agnes Leung. She is the assistant professor at the Chinese University in Hong Kong and a chair of the JAAFCA. She will lead today's program of JAAFCA. We are honored to have her and two of her colleagues, Dr. Paxton Loke and Sigrid. So with this, I would like to welcome all of you, ask you to enjoy this excellent session, and let's interact and continue to work together as Apaaci's JAAFCA. Welcome, Agnes.
Thank you, Professor Ruby. So it's really my honor to be here, to be involved in the first JAAFCA session organized by the Apaaaci. I would like to thank the Apaaaci for creating this channel, this platform, for not only allergy and immunologists who are practicing, but also for all the allergists and immunologists in training, for students, for scientists, and for all the nurses and allied health, including dietitians, to learn more about allergy immunology through this JAAFCA session. So without further ado, I would like to start today's session. So for the overall rundown, so I'm going to start off with sharing you a latest published journal, and I'll talk you through through a journal club. And then I'll hand over to a very an experienced team from Melbourne, Australia. They're led by Dr. Paxton Loke and Dr. Sigrid Pitkin. They're in Professor Mimi Tang's group in the Murdoch Children's Research Institute. So without further ado, I would like to start the journal club now, and I'll share my screen. So just a bit about the session today. So because it's going to be an interactive session, so I would like to introduce you to the Slido platform. So there are two ways that you can access the Slido. The easiest way would be to use your second device, such as your mobile phone, and just scan the QR code. It will lead you directly to the internet page of today's event. On one of the sessions, there will be Q&A, so you can type in any questions during the JAAFCA today, and we'll try to answer your question during the Q&A session at the end. And on the other side of the internet page, there will be a polling session, and we will have some polls today, and we'd very much like to hear what you think. So during the polling, when it becomes activated, then you can it will pop up in the same page. So don't worry. And we'll show the QR code again when the polling is about to come, okay? And the other way, if you have only got one device, you can go to www.slido.com and then just type in the event code, and it will link you to the same page, okay? So I'll walk you through again later in the sessions. So today, I'm very honored to be able to in the same session at Dr. Paxton Loke and Ms. Sigrid Pitkin from Melbourne. And before that, I would like to introduce you to some of the background of food allergy, in particular peanut allergy. walk you through our latest published guidelines, and then I'll hand over to Paxton and Sigrid. So as you all know, food allergy is a global problem. There's an increasing food allergy prevalence both in developing and developed world. So I think the highest challenge confirmed food allergy prevalence reported today was from the HealthNet group. So they challenged all the 1-year-old infants at around like the 12 months old time point. And with the oral food challenge, they noted that up to 10% of these children suffer from some sort of food allergy, and most commonly would be egg allergy. Imagine 1 in 10 of the children have a food allergy. It is definitely a very important global problem that we are facing. So the only measure would be to either fight or flight. So avoidance would be the way to go with the food allergy for the coming years to go. But it has not been a very effective way. You can see, so this is an Australian hospital anaphylaxis admission time trend. So over the years, you can see there's an increasing admission rate for children coming in with anaphylaxis. So it seems that trying to avoid these foods are not very effective, and often we need to use this emergency adrenaline auto-injector. But there are also reports saying that the usage of these adrenaline auto-injector have not been very good, very high as well. So they're often under usage, under recognition, under diagnosis. So this is certainly a problem. So this is why the emerging allergy community has been examining the use of allergen immunotherapy. It has not been a new thing because it has been successfully applied to treat allergic rhinitis, asthma, and even venom anaphylaxis. There has been an attempt to use subcutaneous immunotherapy to treat peanut allergy back in the 1990s, but there is a high rate of systemic reaction, so it has been abandoned for years until recently we discovered alternative routes such as oral, sublingual, or even latest epicutaneous immunotherapy. So for today, I'm going to share with you, and we are going to focus on oral immunotherapy and in particular for peanut allergy. So all of you may have heard about this, the only FDA-approved treatment as of now. So it has been approved since 2020. It's a peanut allergen powder. So in the form of capsules, first launched in the United States. So the treatment, as with other peanut oral immunotherapy, composed of an initial escalation phase occurring in over 1 day, followed by 2 weekly step-up in the peanut dosage until we reach a maintenance phase. So the maintenance would be 300 milligrams of peanut powder. And for that would be equivalent to 1 peanut kernel. And we have to take these peanut daily during the maintenance phase. And the results is actually quite remarkable. So this study was published in a New England Journal of Medicine back in 2018. So you can see at the exit oral food challenge, the children who can tolerate 600 milligrams, which is roughly a peanut pod consisting of 2 peanut kernel, was very high in the group that received the peanut oral immunotherapy. It was almost up to 70% compared to the placebo group here. They can only tolerate, 4% of them can only pass the exit oral food challenge. And this treatment only seems to work in the pediatric age group. You can see over the right-hand side, it doesn't seem to work very well with the adult group. Following that, we also very importantly wanted to know the adverse event that comes with this oral immunotherapy. And not to our surprise, the adverse event rate is actually quite high. So you can see for subjects with 1 or more adverse events, it's more than 90% in both the Paxton, which is the peanut oral immunotherapy group, as well as the placebo group. But for adverse event that is specific to the study treatment, so it's twice as high in the Paxton group compared to the placebo group. And most importantly, there are anaphylaxis cases that occur and is much higher in the Paxton group compared to the placebo group. Most of these individuals suffered from gastrointestinal symptoms, discomfort. Most commonly would be abdominal pain. Some of them have vomiting, throat irritation. So these are the common side effects that comes with oral immunotherapy. We have to be prepared for it. So the same group subsequently went on to do a follow-up study, because this is one of the most important aspects of how we wanted to know how the patients will go on to tolerate peanut in the future. So it looks very complicated, but roughly it tries to arrange the groups into daily dosing group and those with non-daily dosing group. So I think I'll give you the next slide. We will show you a better picture. So for the cohort 1 and cohort 3A for this study cohorts, so they have a daily dosing of 300 milligram of peanut protein daily after the main study. And for cohort 2, 3B, and 3C, they were not advised daily dosing. Rather, they were advised like alternate day, followed by like bi-weekly dosing. So it has been shown here. So for cohort 2, they have been advised twice weekly dosing. 3B and C, so they were also advised non-daily dosing. So they wanted to know the efficacy after the main treatment. So here we'll give you a very good picture about how it goes at the exit double-blind control food challenge. So the highest bar would actually be the cohort 3A, those with a daily dosing cohort for a year. It doesn't seem to work very well for the cohort 1 who also received daily dosing, but only for half a year, so half the time compared with cohort 3A. And then you can also note the other bars, the green, the black, and the yellow bars represent those who receive non-daily dosing. The efficacy is also similar to just cohort 1, half the efficacy of those cohort 3A. So I think it really tells us that. So with longer time to desensitize the patient, the ultimate desensitization rate will be higher. And that daily dosing seems to be better than non-daily dosing. So it seems to be the story that they are telling us. So this is the journal that I wanted to share with you. It's recently published in the Allergy journal, a very high-impact journal. So it looks at the open-label follow-on study evaluating the efficacy, safety, and quality of life with extended daily oral immunotherapy in children with peanut allergy. So please go back and download this article. It's very interesting, but I'll also talk more about in the coming 10 minutes or so. So the aims of the study is really to perform a longitudinal exploratory analysis from the start of Palisade to the end of Apaaaci 004. So it means it from the main New England Journal of Medicine like the study, and then they went on to follow up these children for a year or so. So the research questions that they are trying to answer is to look at the efficacy, the safety or the tolerability, as well as the food allergy related quality of life of having this daily maintenance dose of peanut oral immunotherapy. So this is just a bit of a repeat of the diagram that I've just shown you. So after the Palisade exit oral food challenge, they went on to perform the Apaaaci 004 screening, and then they will be randomized into different cohorts. So for this study here, so they mainly wanted to look at group A as well as group B. So they represented the group with once daily dosing for around half a year, and the group B represented those with once daily dosing for a year. So I'm just trying to separate the group here to give you a better picture. So for this study, they're focusing on the daily dosing group, but for a different time frame. So let's look at the results here. So these are the clinical characteristics of the different groups. So you can see they're more or less similar. So they were roughly around 8 to 10 years of age for the median. So half of them were male, and the majority of them were whites in ethnicity. So they have a similar previous history. They mostly have been diagnosed with peanut allergy at around 2 to 3 years of age. So roughly they have this diagnosis with them for 6 to 8 years. So they have had a few episodes of systemic reactions to peanut before they embarked on this oral immunotherapy, and they have similar comorbidities, including allergic rhinitis, asthma, atopic dermatitis, as well as other food allergies. So this is what the clinical profiles on the screening challenge entering this study. So they have a similar reaction threshold. and that the baseline immunoglobulin level and the skin prick test results seems to be more or less similar, except what I can say is that the peanut-specific IgE seems to be a little bit higher for Group A, the group that only received around 1.5 years of treatment, and the group which altogether received 2 years of treatment. So this is the only slight difference, but the authors did not provide a p-value for the specific table. So, and here is the efficacy figure. So on the left-hand side, you can see this is the percentage of patients who can tolerate different doses of peanut during the Exit Palisade oral food challenge. You can see that most of them can tolerate the one peanut kernel, so the 300 milligram. So the desensitization rate is very good. But as we challenge them with 600 milligram and 1,000 milligram, then the desensitization rate seems to drop a bit. So for Group A, so the groups that can actually tolerate the 2,000 milligram group is just around half of them, 48%. But if you look on the right figure here, so for the group who receive a longer span of treatment for 2 years altogether, they have almost doubling of the percentage of participants who can tolerate the 2,000 milligram of peanut protein. So again, it's trying to tell us that if you take the maintenance dose longer, it seems to improve the desensitization rate. So what about the immunological profiles? You can see here with the purple line, the darker line here, they represent the Group B, the group that has a longer duration of the maintenance treatment. And the orange line here represented the group who have just got a 1.5 year treatment, so they terminated earlier. So so this one shows us peanut-specific IgE. It doesn't seem to further improve the longer you take the maintenance dose. But for specific peanut-specific IgG4, it continues to increase a bit even after the stop of the treatment. So peanut-specific IgG is a blocking antibody, so it helps to protect you from the specific IgE binding to the receptor. So it's a good marker. So for those, just to explain a bit more. And for the ratio, the peanut-specific IgE to specific IgG4 ratio doesn't seem to differ significantly between the group, as well as this peanut-specific IgE, the mean wheel diameter, it's similar between the two groups. And I think we are all very eager to do the treatment emergent adverse event that comes with this peanut oral immunotherapy. So it seems to be quite promising because with time, the exposure-adjusted event rate of having these treatment-emergent adverse events seems to reduce. So you can see the highest is really during the updosing phase, so it's not a surprise. And it seems to reduce during the Palisade maintenance dosing phase. Around 30% of the patients will still experience some forms of adverse events, but it further reduced during the maintenance dosing in the follow-up study. So, and it's similar between Group A as well as Group B here. And we also wanted to know the percentage of patients who really come down with a severe systemic adverse event. So here, I'm just trying to show you for the absolute number, it's actually not that high. So you can see during the maintenance phase, only 7 out of the 110 individuals experience a systemic allergic reactions. And for Group B, it's a 2 years treatment, but only 5 out of the 32 participants, really, they had a systemic allergic reactions. And for those who actually require adrenaline, also is only a single-digit number. For Group A, it's only 7 out of the 110 individuals who require adrenaline and only 4 individuals in Group B. The overall percentage is slightly higher for Group B because the total N is slightly lower in Group B compared to Group A. So the side effects profile seems to be doing okay. So we also want to know how does it help with the quality of life overall? Because treating the patients is not just about the physical health, but also about the psychological and also the social health and how it does to the family. So here is showing you the higher the quality of life score, it means the higher the burden it brings to the family. So the lowering of the score, it means there is an improvement in the quality of life. So you can see here the green bar represented the baseline quality of life. The orange bar represented the time point when they finished the main treatment. And for the purple bar here, what we're really interested in is the quality of life on the exit challenge after the follow-up study. And you can see there is a significant improvement at the end of the follow-up phase. The quality of life scores, it gradually reduce. And it seems to be similar for both the group, but a little bit more significant for group B, especially for the teenage groups. So, and here I'm just showing you those who have a change in the score of more than 0.5, which is a minimally clinical important difference when we have more than 0.5 difference in the quality of life scores. And you can see here, upon exit challenge, there's significantly higher proportion of individuals who have such a difference in the quality of life scores. So it seems to be doing some good to patients' quality of life. And I'm just breaking down here to give you a better picture and what specific aspect that is helping the patient. So for the different food allergy independent measure questions, so there is a significant improvement in question 2 and question 3, which represented the question, will you be afraid to have a severe reaction if you accidentally eat something to which you are allergic? It seems to soothe them a bit about this situation. And for question 3, will you die if you accidentally eat something to which you're allergic? So that there is a significant difference before and after this treatment with peanut or immunotherapy. So here comes really the summary of this article. So overall, it seems to increase the peanut protein tolerability with time. So it seems that when the patients have received 2 years altogether treatment, it seems to improve the desensitization rate compared to the group who have just received 1.5 years of treatment. And with time, safety profile seems to be improving with a reduce in the treatment emergent adverse events. And overall, there's an improvement in the food allergy quality of life as well. So just a bit about the critical appraisal, so please bear with me. So we wanted to know how good is this article. So the first question that we want to ask ourselves is, was the assignment of the patients to treatment randomized? So I have had a look at all the few publications, and it seems they have specifically said that they have randomized these individuals to the different 3A, B, and C cohort. But they didn't really specify if they have been randomized this patient to cohort 1, 2, and 3. They didn't provide a very good randomization rules as to how they assign this patient in the different groups. And you can also see here, so there are a proportion of patients who actually have been assigned to the placebo group during the initial Palisade study. So for these patients, they have been all assigned to the group who received the peanut oral immunotherapy. So I will say yes and no. So I cannot find a very good methodology regarding the randomization here, particularly in the follow-up study. So were they similar at the start of the trial? I have shown you the clinical characteristics table. I would say they have been similar at the baseline, except for a slightly higher than the peanut-specific Ig in the group A compared to group B, but the authors did not specifically provide a p-value, so I'm not sure how big is the difference between the groups. Aside from the allocated treatment, we wanted to know whether groups treated equally. So it was quite tricky for this article because it's not just a normal RCT. It's a follow-on and open label study, which was specifically stated in the title. So I would state they have all been treated equally, all with peanut powder, but with the different regimes, because this is the main research questions that the authors are trying to look into. They differ in terms of the frequency of intake in the second ARC-004 study, and in difference in the duration of the study in the article that I've just presented. And we wanted to know, were all the patients who entered the trial accounted for, and were they analyzed in the groups to which they were randomized? So all of them have been analyzed by intention to treat analysis. But then when I try to compare the figures in the previous study and the latest study by Professor Fernandez Rivas, so the numbers doesn't seem to really match. So for the ARC-004 trial entry, there were 112 studies who were in the cohort 1 and 31 patients in cohort 3. But for this study, you have seen the data that I've just presented. It only accounted for 110 and 32 patients. So the number seems to be a bit odd. So the authors didn't really have specific reports as to the loss of follow-up or the change in the treatment arm. So we should ask Professor Fernandez to talk to us more about the numbers, but I do not think it will make a big difference regarding the efficacy, safety, and the quality of life, the outcomes that they are looking into. So were they blinded to the treatment? So they all underwent the double-blind placebo-controlled food challenge double-blinded manner. But as for the whole treatment protocol, both the assessors and the patients were not blinded because they were well aware of the treatment arms that they have been assigned into. So again, yes and no for this question. And how large was the treatment effect I've presented to you? For group B, there is a 80% of desensitization rate at the exit challenge to 2,000 milligram of peanut protein, which is like double the percentage of those who have completed group A. And for safety, the exposure-adjusted treatment related adverse events also dramatically improved with time, from 56 events down to only 5 events at the end of the maintenance phase. And the food allergy quality of life, it significantly improved with time at the exit of the follow-up study. So it seems to be quite good, but I couldn't find the p-values, how precise was the estimate of the treatment effect. So I'm not sure if it was because of the preprint article that I am looking into, but we really wanted to know the precision of the estimate of the treatment effect. So we can all go back to take a look at the article, and I will encourage you to do so. So will the result really help in caring for my patients? And I will leave these questions to all of you to ponder upon. And then I'll hand over the stage to my dear friend, Dr. Paxton Loke, who is a colleague of mine during my stay with the Allergy Immunology group at the Murdoch Children's Research Institute. So just a bit of an introduction about Dr. Paxton. So he is a research clinician with the MCRI group. He's also the honorary fellow at the University of Melbourne and consultant pediatric allergist and immunologist at the Monash Children's Hospital. So he is a principal investigator of the MCRI-led PPOIT, so which is a very well-structured, very good clinical trial on probiotic and peanut oral immunotherapy. So its aim is to induce a long-term remission to peanut. And he's also the associate investigator of 3 other probiotic food oral immunotherapy clinical trials. So he has obtained his PhD in microbiology, and he's published numerous international peer-reviewed journals and also book chapter and international patent. And with Paxton, so we've got Ms. Sigrid Pitkin here. So she is a senior research nurse coordinator within the MCRI group, and she's also currently the clinical nurse consultant at the Monash Children's Hospital in the pediatric allergy department. So she has just obtained her master's of advanced practice nursing. So congratulations, Sigrid. And she's also have been involved in the numerous clinical trials that I've just mentioned. She's also a very active athlete. So I'm showing you her picture here. So you will see her very shortly, okay? So I'll hand over the stage to them to talk to you about the practical approach to oral immunotherapy. And we welcome any questions, and we will try to answer at the end of the session. So thank you.
Yep.
Hi, Paxton. Hi, Sigrid.
Hi.
Hi, everyone.
Hi, everyone. Yeah, thank you for the kind introduction, Agnes. And today, Sigrid and myself, we are from the Murdoch Children's Research Institute in Melbourne, Australia. And we will be doing sort of like a tag team in one presentation on the practical approach to immunotherapy for food allergy. So this presentation outline, initially we will start off with a brief overview of what is oral immunotherapy or OIT. We'll talk a little bit about outcomes, efficacy, and safety. And then we want to then transit into something practical, where we will talk a bit about barriers to recruitment for OIT trials and programs, the nursing role in food challenges and OIT, and then we'll end off with some clinical trial OIT case studies. So we come from Melbourne. As you can see, this is our beautiful city, but we are still in lockdown. So therefore, we've got nowhere to go, and we are happy to present to everyone in this audience. So we'll start with a question, and Agnes would have mentioned that you can go to the Slido website there, or scan the QR code if you have a second device, and you'll be able to see this question there. If you have only one device, you can go on to www.slido.com and enter the code there, and you can see these questions here. So these questions are meant to trigger off some thinking and some consideration about OIT, and that will hopefully segue into some of our presentation. And the first question is, a 4-year-old boy, Thomas, he has a known peanut allergy. You've seen him because he had a third episode of allergic reaction after eating a peanut-containing snack at a party. And the family heard something about peanut OIT in the news and wants to know your opinion. What would be your advice? So there are 5 choices there, so 4 answers and 1 all of the above. The first one, peanut OIT can help cure his peanut allergy, without which 80% will go on to have a persistent lifelong allergy. Peanut OIT is safe with minimal side effects. Peanut OIT can increase his reaction threshold, and peanut OIT will have no negative impact on his daily schedule, or all of the above. So if you want to put in your opinion or what do you think it is in the poll, please go ahead and press the button. Yeah, that's great. I think the top answer is peanut OIT can increase the reaction threshold to peanut as to reduce the chance of accidental reactions. And that can be seen in the Journal Club article which Agnes has presented. All of the above may be true as well to a certain extent. If you look at the literature, there will be description about in a way that you can say that there are some effects with peanut OIT which is not 100% safe as well, and there will be some negative impact as well. So we can go on to the next slide. Okay, so let us begin. So the burden of food allergy, as you know, is increasing and there's no cure. So food allergy is a global health problem, and up to 5 to 10% of the population in developed countries, including 10% of infants in Australia, have a food allergy. More than 32 million people in the US have a food allergy, and the economic costs have been costed to about US $4,184 per year per child in the US. In Australia, as you can see on the table on the right here, the rates of food anaphylaxis hospital admissions have increased more than 3-4 in the past decade. There is no cure for food allergy at this point in time. Patients are asked to avoid the allergen, but yet 50% have an accidental reactions within 1 year. And the quality of life is severely impacted, and which is found to be equivalent to diabetes, and deaths can be unpredictable from food allergies. So what is the current management of food allergy? In Australia and New Zealand, the current management is strict avoidance of the food itself, where patients are taught how to read ingredient labels and to be aware of cross-contamination. And we provide an action plan for the emergency management of reactions, as you can see on the right, we have 2 plans, one for allergic reactions and one for anaphylaxis. For a certain subpopulation, a provision of an adrenaline auto-injector, such as the EpiPen or the Anapen, and in certain countries they have different names, will be provided to the patients. And clinicians will optimize the conditions such as eczema, asthma, and allergic rhinitis in food allergic children in order to optimize their care. And when their skin prick test or specific IgE is decreasing or approaching negative, oral food challenges in a clinical setting or reintroduction at home can be performed in order to test and find out the resolution of food allergy. But as you know, there is quite a lot of persistence in food allergy, especially with peanut, tree nuts, seafood, and so on. So let us begin by looking at some definitions. So what is the possible outcomes that we can find from a food allergy treatment? And I'd like to introduce to you a few terminology because that will span the rest of our presentation here. The first terminology is desensitization. So what is desensitization in a food allergy treatment? It is the temporary increase in the threshold of allergen reactivity that is only maintained by ongoing regular allergen exposure. The duration of protection is transient and you require regular treatment or ingestion to maintain protection. You must continue to ingest the treatment or the allergen in the OIT program, but you must continue to avoid the allergen itself in settings such as schools or in restaurants and so on, because the allergy is still present. And how do you assess for desensitization? You assess for desensitization, or DS for short, is by passing a food challenge while on treatment. Now, the second column, sustained DS or sustained desensitization. It is not a commonly used term at this point in time. It's like an offshoot of desensitization. The duration of protection is still transient, and you do require regular treatment to maintain protection. But it is the ability to maintain DS using longer doses, or if you use an extended period in between doses, but the injection itself is still regular. The allergy is still present, and to assess or sustain DS, you can pass a food challenge, but at a lower eliciting dose after you finish your OIT program or treatment. Now, the second terminology or outcome is known as sustained unresponsiveness, or SU, or can also be known as remission. Now, this is a sustained ability to tolerate the allergen after you've completed an OIT clinical trial or OIT treatment. The duration of protection is longer lasting, and you do not need regular treatment or injection to maintain protection. Patients who achieve SU can introduce food freely in the diet, and you assess SU by doing a food challenge weeks and months after treatment has been stopped. And the last outcome from a food allergy treatment is tolerance. Tolerance is the holy grail of an OIT or food allergy treatment. This is a permanent ability to tolerate any amount of food after treatment is stopped. You do not require regular ingestion, and food can be freely introduced into the diet. There is no real test for tolerance in a clinical trial or OIT program because it does not go on forever. But one way to assess for tolerance is to assess for SU, or sustained unresponsiveness, that persists years after treatment has been withdrawn. So which means you do your SU challenge 3, 5, maybe 10 years after treatment has been stopped, looking at this as a surrogate marker of possible tolerance. So what is OIT? Now, OIT is the daily ingestion of food or allergen over months to years. We start off with micrograms to milligrams, and then from milligrams to grams. The 3 phases of OIT program, OIT clinical trial, starts off with the rush phase. The reason for that is you need escalating doses to slowly induce desensitization in the first instance. The rush phase is a rapid escalation of micrograms to milligrams, followed by a regular interval escalation, so a build-up phase of milligrams to grams. And then the maintenance phase is a fixed dose or fixed target dose of milligram to grams. You can see a schematic on the right here in this slide here. At the end of the therapy or the OIT, you perform food challenge, you assess for desensitization. And then you assess for time of therapy. So remember, you're looking at the second outcome, which is SU. So you need some time off the therapy, a period of allergen avoidance to assess for SU. And most randomized controlled trials have focused on peanut, milk, and egg. So this is the schematic OIT for food allergy in a bigger form. As you can see here from the beginning, you have the screening or baseline challenge where you enter the patients or the subjects or the participants, and you have this dose escalation, which is quite rapid, which is the rush phase, typically over a day or sometimes 2 days in certain protocols, and then followed by a build-up phase, which is usually 1 to 3 weeks with an average of 2 weeks, which is like a step ladder to reach this phase called maintenance phase. Now, maintenance phase can go on to months to years. In the Palforzia trial, their maintenance phase was about 6 months. After you reach the end of your treatment or the maintenance phase, you perform a food challenge. And in clinical trials, we perform double-blind placebo-controlled food challenges to assess for desensitization and a period of time of therapy to assess for SU, which is the sustained unresponsive outcome. Now, after you attain SU, more and more researchers and clinicians are interested in the post-treatment follow-up. What does it take to maintain your desensitization or your SU in terms of having, ad libitum, which is free eating of the allergen, or regular ingestion? So this is again a pretty exciting, hot area of research. What happens post OIT? So in the next few slides, I'm just going to touch on very quickly on the efficacy and safety of OIT when we look at the outcomes of desensitization versus SU, and also the unmet needs in research. So there's a lot of unmet needs in OIT research, which we will not focus in this talk today. But I'd like to then introduce to you the efficacy and the brief safety of OIT comparing DS versus SU. So in this very quick snapshot, we are looking at the efficacy of DS outcomes versus SU outcomes of the major food allergens, including egg, peanut, milk, and occasional tree nut, walnut, hazelnut, and wheat. So all these are published data, and we can see the desensitization outcomes are slightly higher. You can achieve up to 90 to 100% of desensitization outcome for some allergens like egg and milk, but not very well for the wheat allergen and some tree nuts. The SU outcomes are slightly lower, but remember the SU outcomes are higher bar, so it is a more difficult outcome to achieve, but you can also achieve SU up to 30 to 40% of certain allergens, and that allows the patient or the participants to have a slightly more liberal or free eating after completion of the OIT program. And in our group at MCRI, our goal is to assess for remission or SU outcomes in our clinical trials. So what about the safety of OIT? So a systematic review and meta-analysis of peanut OIT published in the last few years have shown that desensitized patients on OIT have more allergic reactions than patients who are avoiding the allergens. So they have 3 times more anaphylaxis, 2 times more adrenaline for reaction, and high rates of treatment discontinuation, as you can see on this forest plot on the right here. And in another meta-analysis or review showed that, taking all studies, including RCTs and non-control studies, peanut OIT resulted in adverse events requiring adrenaline in 7.6% of patients studied. So when we talk about OIT dosing consideration, there are a lot of restrictions to remain desensitized. You need to take the daily dose at about the same time to be consistent. Some protocols have advised at least 8 hours between doses. So if you take 1 dose in the evening, you need to make sure that it's not too early the next morning. So a consistent time is usually part of a daily OIT clinical trial or daily OIT program. You need to take it as part of a meal. You must still avoid all other foods containing the same allergens. So for example, if you're on peanut OIT, you need to avoid all other peanut containing foods outside of the program as well. It is a bit less stringent for OIT in a clinical setting than for clinical trials. patients and families must be prepared to manage allergic reactions, including anaphylaxis and systemic reactions. They need to be aware of lifestyle restrictions. And no study has yet evaluated patient adherence to this kind of restrictions, which we'll talk about a little bit later as well. Now, for long-term follow-up studies of OIT, this is a review that was published just beginning of this year. And you can see there have been studies looking at long-term follow-ups of peanut, egg, and milk. And you can see about half, and some studies more than half, 70 to 80, 90% are still consuming some form of allergen after completing their OIT. But what is of interest here is that anaphylaxis is still reported, especially for this milk study, up to 5 years post-OIT. And anaphylaxis has been reported at least once by about 19% of all subjects in the trial. So reactions still occur in long-term follow-up studies of OIT, even as they continue to ingest the allergen. So the goals of OIT therapy. Now, there are sort of different goals that clinicians and researchers think about. Are we looking at protection against cross-contamination? So they may contain food in food labeling, for example. And what about protection from larger accidental exposure, which is bite-proof? So if you bit into a peanut butter sandwich or you bit into a peanut, will you be protected against that? And what about free eating? So our goal at MCRI is to allow for regular ingestion of free eating as the goal of our OIT clinical trial program. For example, we all know that food allergic children is a very heterogeneous population. There are some who are more sensitive and there are some less sensitive. And different trials have used different maintenance doses. Some have used low dose maintenance therapy, 150 to 300 milligrams, and some use high dose as part of their maintenance program as well. So just to, I think, end off this section, we talk about adverse events in OIT, so reactions. And these are some of the considerations that have been published in literature, that severe reactions in OIT appears to be anticipated and recognized and treated promptly by the parents, because we tell them that you are eating the food allergen you are allergic to, and they have an anticipation to know that, to recognize the reactions that may occur. So the reactions with OIT may be considered expected, whereas if you compare to accidental reactions with avoidance, where you go and eat and you don't know what is in the dish, that is unexpected, and that might be more alarming to the child and to the family. Home dosing reactions may be considered less anxiety producing versus the constant fear of living day to day with the uncertainty of a food allergy. And food allergy treatment itself may have a positive impact on quality of life, irrespective of the outcome. So to end off this section, OIT outcomes is a continuum. So we aim for desensitization at the end of treatment. We look for sustained DS in some trials, but the goal of SU and remission should remain a top target in the sense that we allow patients to have less structured intake, reduce reactions possibly, and increase quality of life. And of course, long-term SU or possible tolerance can only be performed if you are looking for SU itself as the outcome in your OIT trial, OIT program, and that can only be assessed after many years post-treatment. So I'll pass on to Sigrid, and she will introduce the poll for the second question.
Yep. So as Agnes and Paxton said before, if you could please participate in this, it'd be good to see what everyone thinks. So you can use if you've got a second device, you can use it to scan the QR code up the top. Or if you've only got the one device, you can go to slido.com and enter in the number for our session, and then you'll get the same questions. So there's a number of patients who want to join your peanut oral immunotherapy program. Which conditions would be considered red flags or raise alarms? There's all of the above: a patient with comorbid asthma, a patient with recent diagnosed subventricular tachycardia, a patient with autism spectrum disorder, or a patient on dust mite immunotherapy? So I'll give you a little bit of time to answer. Okay, so it looks like most people are going with all of the above, 81%. So look, some of them are, and some of them it depends. So patient with comorbid asthma would definitely raise a red flag, but you can also, if it's well managed and they're on a preventer and they only need to use their reliever or Ventolin, less frequently, once a month or only when they're unwell, then it's fine for them to have asthma. But of course, it needs to be something you're aware of. A patient with the supraventricular tachycardia, again, not so much of an issue, but then you need to look at the implications of giving them adrenaline if they need treatment. Is that going to be an issue? So any cardiac condition needs to be okayed by their cardiologist if it's managed by them. A patient with autism, again, depends on how severe that condition is. So we have quite a few people who are able to partake in oral immunotherapy and with our clinical trials. We just need to be aware of what their triggers are for their behaviours and things like that. But obviously, if it's someone who's got quite a severe or further down the scale on the spectrum, then it might not be suitable for them to participate. And a patient on dust mite immunotherapy would actually be, for our clinical trials, would actually be not able to participate, just in case they had a reaction to the immunotherapy, but also it's modulating the immune system. So we want to make sure that what we're giving them is going to be able to have full effect. So being on other immunotherapies is an exclusion criteria for our clinical trials, but perhaps not for immunotherapy if they've been on treatment for a while. Okay, so let's go on to the slides. So I'm just going to talk about barriers to recruitment and the nursing role in oral immunotherapy and oral food challenges. So next slide, please, Paxton. So barriers to recruitment. So there are a lot of barriers when you're looking at recruiting for either clinical trials or oral immunotherapy. I'm going to be talking more about the clinical trials that we do here, but I think it can be all applied for oral immunotherapy anyway. So the biggest reason why we find that people don't want to participate is the time commitment. So, initially we've got couple of days where people come in for their food challenge, and then they've got the build-up appointments every 2 weeks, which go for a couple of hours, and then they've got the maintenance phase. So they're having to have the dose every day. They're having to come to hospital regularly. So for a lot of people, that's not possible. Depending on the population where you're based, in Melbourne, Australia, most likely both parents are working, so it's quite difficult for them to find the time to get off work to come and bring their child in that often. But having said that, we have people who travel 5-6 hours from the border of our state to come in and do it. So it depends on the family and their situation. Another concern that families have is their likelihood of reaction. So a lot of parents are very scared about reactions, particularly with our trials where we have an entry food challenge to confirm the allergy. So they kind of know that a reaction's coming, and that frightens a lot of families and a lot of children. And some families don't want to put their children through that, which is fine, but it just means that they're not able to participate. Some families, so children, obviously, as Paxton showed before, have either an allergy plan or an anaphylaxis plan. So if they've got no previous history of an of anaphylaxis, they'll get a green plan and they don't need an EpiPen or adrenaline auto-injector. But if they have had previous anaphylaxis, then they've already got one. But if they've only got the green plan, if they're part of the trial or they need to, or they're going to do oral immunotherapy, it's highly recommended that they have an adrenaline auto-injector, because when they're avoiding the food, they've been shown that they don't have anaphylaxis, but when they're actively eating it, there's obviously a much higher risk of anaphylaxis, so they need to have that EpiPen or adrenaline auto-injector. So that can be a bit of a hassle in Melbourne in particular, because you need one for the school, and if they go to before and after school care, another one needs to go there, and then you need one at grandma's and grandpa's. So, you know, it can be a bit of a hassle having to keep up with maintaining those. For clinical trials, there's a placebo arm, and for a lot of people, it's not worth going through that time commitment and carrying an EpiPen or auto-injector and all those things and going through the challenges to be receiving sugar for the duration of the trial. So for some people, it's not worth it if there's a chance they might have placebo. And for a lot of people, again, like I said, the entry food challenge, which is normally double-blind placebo controlled, scares a lot of people, because they don't want their child to react and they don't want to have to put their child through that. So those tend to be the main reasons why people don't want to participate when we're doing the screening. Next slide, please, Paxton. So these are 2 cities that we had, and you can see the reasons why people aren't eligible and then the reasons why people declined. So it really depends on the population of your area, because it can vary greatly between states and then also, again, between countries. So reasons we've got for not eligible, we've got outside age range, outside recruitment area. So with one of our trials, we only recruited within Victoria, and we had lots of people from other states interested, because in Australia currently, you can't actually get oral immunotherapy from private clinicians. So, you know, in where you are, there might be you might be able to access oral immunotherapy. So you might find that you've got less people willing to participate in clinical trials because of that. But in Australia, we've got lots of very keen families, people promising they'll move from different states to Victoria to get on trials and things, because they just really don't have any other options. Reasons not eligible, we had, you know, there's a few people who might have had severe anaphylaxis. So we define severe anaphylaxis as needing 3 or more doses of adrenaline. If they had collapse, or if they needed like an adrenaline infusion. So it had to be pretty, you know, quite bad anaphylaxis to be ineligible. If they had an underlying medical condition, so some people have like the conditions like idiopathic urticaria, which obviously could be troublesome if you're either on active or placebo, or you're receiving the treatment and all of a sudden they're breaking out in hives for no reason. That could be quite difficult to manage and work out what the cause is if they've got those conditions. And also, you know, could be a cardiac condition or poorly controlled asthma, something like that. On a ladder diet, so generally if they're introducing the foods over time already, then they're not really a good candidate for the trial. That's sort of more for the milks and the eggs, obviously, rather than the peanuts or nuts. Already eating allergens, some people were already eating a less cooked form of the allergens, so they weren't eligible. And then just some other reasons that we don't normally mention. And reasons declined, you know, a lot of it was too time consuming, too many visits. There was a placebo arm, concerns about adverse events. And then some people just didn't tell us why they didn't want to participate. So there's sort of, you can see a lot of different reasons why people might not be eligible or why they want to decline. But it's really good to know these sort of things before you go to set out a program, so that you can make sure that those sort of things are addressed before you get consent and before you enroll people, because then that can really help with reducing the amount of withdrawals that you have during the trials. Obviously, if you're doing a trial or you're doing oral immunotherapy, but more so for trials, you really want to make sure, you know, you've calculated the power that you need and the numbers that you need for the study. You want to try and keep your withdrawal rate to a minimum. So, yeah, if you can be aware of why people might not be eligible and why they might decline, then you can sort of cover information on why, to sort of try and address these reasons from the families. Next slide, please, Paxton. So important considerations when you're talking to families about them participating. Informed consent. So this is like one of the biggest things, I think, is really making sure that the families understand. With our clinical trials, we email out the consent form before we even talk to them so that they've got time to read over it. Then if they're still interested in participating, they'll email us and let us know, and then we'll call them. And often people are like, yes, I want to participate. And then you start going through everything with them and going through the consent form. They're like, oh, I didn't actually realize that. Oh, that's a bit, isn't it? So you really need to make sure that they actually understand what they're signing up for, including all of the risks and the likelihood of risks. So, you know, as Paxton and Agnes said, you know, the people on oral immunotherapy, you're still going to have reactions. You're at a higher risk of anaphylaxis than from avoiding the food. There's things that we can do to decrease the chance of having that reaction, like no exercise, no hot showers, have it with a meal, those sort of things. But there's still, you know, a risk that there's going to be reactions. You can explain the treatment for reactions. So it's okay if they have anaphylaxis, they're not going to be excluded, but it just might mean they need to go down a dose or go a bit slower, those sort of things. And if you've got children who are older or mature, make sure you include them in the discussion. So anyone pretty much over 10 we'll include in the discussions. Anyone under 10, we sort of say you hop on the iPad and we'll talk to mum and dad about it. But, you know, include them in it, ask them if they've got any questions, because they're probably going to want to know some information as well about what's happening. And they often have really good questions. And really valid questions that are appropriate. So, you know, don't be afraid to include them in the discussions. And like I said, allow the family to consider the participation. So once we've emailed consent form and we've had a chat over the phone and they're like, yep, we're keen to go ahead, then normally we'll actually say, look, do you want to book in now or do you want to go back and talk to your family about it again? And about half of the time they'll book it in, but half the time they're like, no, let's go and talk about it again, because we really want to make sure that they know what they're doing. They need to make sure that they've got the resources in place to be able to get to the visits, and that work's okay with it if they need to take time off work, or that, you know, other caregivers are happy with participation. Next slide, please, Paxton. So the nursing role in oral immunotherapy and oral food challenges for the nurses. So, you know, you guys are really at the front line. So, you know, the doctors are there and they'll do the medical assessments and be sort of overseeing the clinic. But, you know, you guys are at the bedside. I'd like to say we're the most important people, but, you know, I think the doctors here might not agree. But, you know, it's really important that we build rapport and a trusting relationship with the families. So these families are going to be coming in for the next two years, you know, 18 months. So you really get to know them. So it's really important that you build a relationship with them. You're going to be expected to provide emotional support. You know, sometimes the families have other things going on in their life, and you can sort of pick up on that when they come in for visits. So just, you know, being there for them and saying, oh, is everything okay? And how's it going? And asking how their week's been or their fortnight's been. Finding common interests with the kids as well. That always helps when, you know, in Australia we've got football, so a lot of the kids are football mad. So then when they come in, you know, asking how their team went or saying that their team had a good win makes a big difference with them. And also just little things like trying to remember parents' names, or just looking up the parents' names before they come in. So then you know, oh, here's Bobby and his mum Sue. So then when they walk in, it's like, oh, hi, Bobby. Oh, hi, Sue. How are you going? So little things like that can make a big difference for the families in terms of building those relationships. You can offer age-appropriate tips and tricks to help with doses. So, sometimes you sort of say with younger kids, you can put it, mix it in ice cream for dessert, things like that, or if a child's sort of having a bit of trouble with the restrictions for exercise, then suggest maybe moving the dose from the morning to the evening, just before dinner. So then you know that they're sort of winding down for the day, those sort of things. Whereas with an older child, here in Melbourne or Australia, we've got lots of children who, if they're a bit older, they've got lots of after-school sports. And as you get older, the times get a bit later. So if you've got sort of teenagers, then often their sport is sort of 6:30, 7, 8 o'clock at night. So it's not appropriate to be having dosing at 7 o'clock at night and then going and playing a game of basketball at 8. So, trying to give them tips and tricks to work around their schedule also helps. Also providing medical advice within the scope of practice or with medical guidance. So if they're asking, recently with COVID vaccines, we've been getting lots of questions about vaccination for children and those sort of things. So make sure you're giving advice within your scope of practice or seek guidance from the medical staff and then sort of hand that advice on. Next slide, please, Paxton. So, some of the tips and tricks. So the timing of the dose. So like I said before, different ages, it's probably going to be better to do it at different times. And also depending on the your population, when you're most active and when children are most active. So, in Europe, you have in Spain, they have the naps during the day, and then they're up quite late at night. So, perhaps late in the evening might not be a good time to have it, whereas it might be better during the middle of the day. So depending on what's good for your population, timing of dose is important to try and minimise the impact on lifestyle, I guess. What to mix the dose with. So generally, as a general rule of thumb, anyone with food allergies generally got a taste aversion to that food. Peanuts are a particularly hard one to to hide the flavour of, whereas milk and egg, you can sort of mix it with other things and hide the taste a little bit, but with peanut, it's a little bit difficult. Trying to offer alternatives to what to mix the dose with to make it a bit more appetizing for the children, particularly if they're having trouble getting the dose in with the younger kids. Troubleshooting. If parents are having trouble getting it in, or, having, their child's having little tummy aches after every dose, then just trying to work through with them that maybe, depending on your protocol and medical guidance, maybe pre-dosing with antihistamine for a few days might help relieve the anxiety of the child. That might be just enough to get their body over the line, or they might be brewing something. So trying to work through, trying to help get the dose in and minimise anxiety at home, and sharing recipes. So over our trials, we've had quite a few families come up with their own little recipes to hide mainly the peanut, because like I said, the egg and milk's a bit easier to disguise in things. So this is one family offered this recipe, which is dairy-free, grain-free, additive-free. It's like a chocolate drink powder. So they make it all up, and then you could just take out a tiny bit and mix it with the peanut flour that we were giving them. And then it just comes into like a chocolate yogurt kind of thing. And then the next recipe we had, which was a bit of a favourite, was actually quite yummy. We got to sample some as well. One of the families, their parent was a scientist and loved research, so they went and did some research on hiding the taste of peanut, and they found, as you can see, they did a little thing at the bottom that it says you can hide up to 15% of peanut in as little as 13 grams of the recipe. So, yeah, they were pretty scientific with their calculations on how much you could give your child. But obviously, you know, you want to share them with caution just in case people had other allergies to other foods. But as you can see by that list, there's not too much that you could, you know, there's margarine instead of butter. Or, you know, you can use your Nuttelex, which is dairy-free. There's not too much in there that kids would be allergic to. So, yeah, it's a really good alternative. In one of the other cities that we did a study in, the families put together a recipe book and shared the recipes. So it's really good to get, you know, sometimes the parents, when they're coming in for visits, just have chats amongst each other, and that's good too sometimes, I think, offering each other support for families who are going through a similar thing. And I think that's it from me.
Yeah, thanks, Sigrid. And yeah, the next question, which you can participate in the poll as well. So the Slido poll, the same code. And so you have this boy again, Thomas. So he started on his peanut OIT. And which of the following conditions should his parents call the clinician for advice? I'll let you guys, the audience, put in some of your response, and I'll go straight into the presentation of the clinical cases. 100% for yes, and so on, and a few other things. Yeah. Yeah, I mean, in this question, you can sort of argue that perhaps almost all of them that his parents can call a clinician for advice. Perhaps not the change of delivery vehicle from banana to crackers if there wasn't any issues, but our clinical team or nursing team, and of course I like to want to say that the nursing team is very important. Would be able to handle majority of these questions for Thomas. So I'll just carry on with the presentation. As you guys are still putting in. All right. All right, I'd like to carry on with some case studies in clinical trial OIT. And I'll start off with the first one with a 2-year-old boy in a peanut OIT trial. He failed our peanut challenge at 100 milligram. His peanut skin prick test was 10 millimeter, and his specific IgE to peanut was 5. So he was on this build-up dose at home in the up-dosing phase. As you know, the build-up dose is after the rush phase. So they come to the hospital every 2 weeks to get his dose increased. And in that 2 weeks, they continue the same build-up dose at home. And then 30 minutes after taking the dose, he developed widespread urticaria and erythema. What should the parent do or should have been advised to do? So for every child or every patient, they have a home dosing management plan, which we advise them to always follow their allergy or anaphylaxis action plan, which we provide to them. And in the plan, it says that if you have a certain symptoms such as urticaria, abdominal pain or vomiting, then you will administer antihistamines and you observe for any progression. If the child then develops signs and symptoms of anaphylaxis, the adrenaline auto-injector must be administered and the ambulance is called. Now, we have a 24-hour, 7-day-a-week on-call study clinician, which the parents and the patients can call for advice. But we always advise them to, if there's a reaction, you need to treat the reaction first and then call us, rather than to delay treating the reaction. Sometimes the parents treat and then call us, but the reaction is still happening in the background. We can still provide a sort of a real-time advice if required. Now, the on-call doctor or study nurse will then provide advice regarding reaction management. If there's a progression, we always check for cofactors. So is the child having an asthma exacerbation, or the child is unwell, or a child has just had some exercise after having the dose. And then we provide advice for further dosing and plus or minus prophylactic antihistamines. So what about dose adjustments? So as part of the clinical trial protocol, we have dose adjustment strategies. So in certain contexts, we allow the reduction of the dose, sometimes to the previous dose or 2 to 3 doses down. Other trials, other protocols, or other programs use a percentage reduction, perhaps 25 to 50%, and sometimes up to 75% reduction of the previous dose before you go up again. We always educate and support the patient and the parents on home dosing reactions. And you always need to have a plan for reactions at home, how to adjust adjustments at home if required, and you need to bring them back to hospital for dosing adjustment if the reactions are severe. And you need to always have a plan for hospital updosing and an on-call service for patients and parents to call. So general instructions and rules for OIT dosing. There's a lot of rules. If you look at the Palforzia, which is the FDA-approved 300 milligram peanut protein, if you look at the product information sheet, there are many, many rules. We generally advise dose taken at the same time to establish a routine. You must avoid all other foods, not at an empty stomach, not during menstrual periods, and avoid strenuous exercise for 2 to 4 hours post-dose. Other protocols say don't exercise 30 minutes and up to 1 to 2 hours after. So as you can see, the general rule is about 2 hours. Do not take the dose during active infections and definitely not when having a fever. And some protocols say not within 2 hours of bedtime and not with asthma, excessive tiredness, and not the same day as vaccinations. And with all these rules as well, we do have instructions for missed doses or sick day management. So the OIT dose may be withheld after discussion with the study clinician, and in some cases must be withheld, especially with a febrile illness, especially with any severe asthma exacerbation or even severe allergic rhinitis, or any condition that might lower the reactivity threshold or is a potential co-factors. If a child has any of this, they need to withhold the OIT dose. You can use prophylactic antihistamines may be considered in terms of giving antihistamine before having the dose. And if you had any missed doses, so for example, you miss 5 days of OIT and you need to up dose again, which means they step up, you need to perform this dosing again in hospital. So some general rules, some trials will allow up to 3 days and you can continue the same dose. Some, after you miss more than 3 days, you have to come back and have the dose in hospital due to risk of a reaction. And if you miss more than 7 days, you definitely need to reduce the dose. And the patients are always encouraged to call the clinical trial team if they are uncertain. And some of the reasons for missed doses, which sometimes is unavoidable, family events, holiday travel, busyness is quite common. The family, the parent may forget giving the dose, and camps. So in Australia, we do camp starts in grade 3, and sometimes we don't encourage them having the dose in camps because the teachers will find it very difficult to manage. So they can take the dose on the day before they leave for camp and after returning from camp. Shorter camps are easier to manage because you miss less, but if you go for a longer camp, they then come back to the hospital and have the same dose again under medical supervision. And those refusal can lead to missed doses as well. And Sigrid mentioned, you come up with recipes, you give them a lot of emotional support in order to take the OIT dose. And then some parents do lose the doses. And when they go overseas, when we can go overseas, time zone differences, and you can get all sorts of other unrelated illnesses such as dental work, accidental injuries due to fractures and surgeries as well, leading to missed doses. So that's the first clinical case which I'd like to introduce. Now the second one which I'd like to introduce is think about a 10-year-old boy in a peanut OIT trial. Well, he failed his challenge at 300 milligram. His peanut skin prick test is 15 and his specific IgE is 50. Now he also is on the build-up dose. But 3 out of the 7 days at home, he will have vomiting and abdominal pain about 30 to 60 minutes after the dose. You try to adjust his dose downwards, and he tolerated a little bit. and then you go up again, but he has similar symptoms, and then you down-dose again, and then he again developed recurrent abdominal pain. And this is despite you giving him, antihistamines before the dose. But when you tell him not to have the dose, let's say you give him 1 week free, dose-free, a break, he has no symptoms, absolutely symptom-free. So, for example, this is a chart, and you can see that these are the doses. Like for him, for example, the blue dots are the reactions. So that he doesn't have really a lot of symptom-free days while on the dose. So when we try to increase his dose, he gets symptomatic, and then he goes up, and then we bring him down again, he gets symptoms, bring him down again, and then bring up again, and he has symptoms. So you can see this fluctuating symptoms that occur. Now we did try him off 2 weeks without the dose, and he has no symptoms. When we start again, he gets recurrence, and this is going on for 6 to 8 weeks. And what would you do? What would you think about for this patient? So is this IG-mediated symptoms, or is it something more chronic? Now, if someone on OIT has had recurrent abdominal pain on a very consistent basis, plus minus vomiting, or any other symptoms of dysphagia, we need to think about EOE. So EOE is a chronic condition that may occur and is a side effect or adverse event due to OIT. And for this case, we refer to gastroenterology, so our gastro team, and he had a gastroscope, and histology showed confirmed EOE. You can see these little diagrams here. The first diagram on the left here is a normal esophagus, and the other 3 diagrams are showing signs and symptoms, signs of a EOE here. So when you see his OIT, he's asymptomatic, and our gastro team for this child decided that he didn't need any treatment, and he had a scope again 10 months later, which demonstrated histological improvement but not completely resolved. So I'd just like to briefly touch about abdominal pain and EOE in OIT. Now, abdominal pain is very frequently reported in OIT. Up to 85% of patients can experience one adverse event of abdominal pain. EOE itself is a contraindication for starting OIT. So if you have EOE before starting OIT and it's not resolved or completely, it is a contraindication. And literature talks about an EOT-like OIT-related syndrome versus EOE itself. Now, when they mention this kind of symptom, they basically basically talking about abdominal pain and vomiting, which is chronic, but they have not had a histological diagnosis or gastroscope of EOE. And meta-analysis have shown that about 2.7% of patients on OIT may develop newly diagnosed EOE. And some studies have reported up to 8% EOT in their program. Now, there's also this concept of some patients may have existing EOE, so undiagnosed, and it may be unmasked by the OIT itself. And again, adverse events and adverse reactions are often the main reason for stopping OIT. Up to a quarter of patients may stop OIT because they're having an adverse event. So from these 2 clinical studies and also what we talk about the practical approach, so OIT itself is a very exciting area of translational research. It is an area which is emerging, and there's a lot to learn about OIT for our food allergic patients. To set up a program or clinical trial, it is resource intensive. It requires extensive preparation, and the most important thing we really need to consider is the safety of our participants and our patients, that they are not worse off after starting a clinical trial OIT than before. And members of the team, including medical, nursing, dietitian, and so on, are both or all equally important in an OIT clinical trial or OIT program. So my last slide here just shows, and you can see this in this paper at the WAO journal, so many components of a shared decision making for making an informed choice regarding OIT. So you have the doctor's role, the family's role, and so many things to talk about here: options, benefits, and risks. So I'll leave this here and this diagram here for your consideration, and we can take some questions. Thank you.
Thank you, Paxton and Sigrid, for the very insightful talk, and we've learned a lot from both of you. We've actually got quite a lot of questions from the floor, and I would like to you guys to help me out, okay? So, Sigrid, we've got a question here. So, how to boost up recruitment and how to screen out the not eligibles one, I think, at an early stage. Do you have any strategy for that?
Yeah, so what we, over the course of doing quite a few different trials, we found that that's one of the most labour-intensive parts is talking with the families on the phone and then finding out, halfway through the call they're not suitable or they've got a condition that's not eligible. So what we actually developed was we've got access to a research database, which, I'm sure you could set up a Survey Monkey or something if you don't actually have access to a research database like us, that actually asked all of the main screening questions sort of in plain language and in a way that didn't let on to the family what would exclude them and what wouldn't, because some families are pretty cheeky and will lie about things so that they can get on the trial. So it would ask them, where they live, what their age is, what the child's age is, what their last skin prick test was, when they last had a reaction, what's the worst reaction they've ever had, do they have EOE or are they being investigated for EOE, are they on any other immunotherapy, sort of those sort of questions. So before we've even contacted them, we've got all that information so we can screen through it. If there's something that comes up that we're like, oh no, they can't be part of the trial or part of, this, they're excluded, then we can just email them and say, thanks for participating in that survey. Unfortunately, because of this issue, your child's not eligible to participate. So that saves us a lot of time. And that's a really good way to see interest as well, because if you have 200 surveys filled out and only 4 people are eligible, well, maybe you need to look at what you're putting out there in social media or advertising when you're trying to recruit people. Maybe you need to be a bit more specific with that to target a more targeted approach.
Thank you, Sigrid. It's a bit of an art and science mix of
Yeah,
both.
it is. It's tricky.
I've got a question here. Maybe I can answer that. Is, do you think peanut allergy is common in Asian Pacific countries? And do we have any numbers regarding peanut allergy prevalence in Asian countries? I would say it's we do not have very good data, especially challenge-proven data. The only one data that we've got is from the HealthNet study. But from other different Asian Pacific regions, we have got the IgE, we've got IgE together with a convincing history. And most of the Southeast countries, the prevalence is not that high. Most of them are like 1% or even less. For example, the Gusto cohort from Singapore, I probably have a lot of Singapore friends here. And also the Indo-Prevail, the Euro-Prevail study involving China, Russia, and India. All of them have a peanut allergy prevalence of less than 1%. But speaking aside that, we have got an increasing prevalence of anaphylaxis incidents all around the Asian Pacific countries. And I would say peanut is top culprit of the severe allergic reactions. So we really need more good data among the Asia Pacific region. And I need you guys to help us to get these data to show us that peanut allergy, although it's not so common in the past, but it may be on a rising trend. And in fact, it tends to lead to severe allergic reactions. And there would be a lot of potential candidates for these peanut immunotherapy. So we all need to learn more about it. So I hope that answers some part of this question. And can I have Paxton to answer some very intelligent questions about SU? So for how many months or years after descent for an SU? So I think we have 2 similar questions about that.
Yeah, so in terms of testing for SU after DS, different trials and programs have used about between 4 weeks to 12 weeks. And we at MCRI is using 8 weeks. We feel that at least somewhere more than 6 to 8 weeks or 6 weeks to 10 weeks would be an ideal case to test for SU, because you really need a long enough time to assess for, whether are you testing for real SU effect as opposed to desensitization, which will then only be transient. So I think a good consensus is somewhere between 6 to 10 weeks, and we use 8 weeks at our trials here.
Thank you, Paxton. And I've got a difficult question here. So how could we differentiate patients that are more likely to achieve SU from OIT? So I think the question would be, are there any biomarkers that could predict the success of an OIT?
Yeah, this is a quite area of research, and the response have normally been seen in those which perhaps have a lower peanut IgE rather than skin prick test. In fact, specific IgE, it's a better marker of prediction of success, or the more likelihood of obtaining your outcomes. And if you want to increase success rates for ORT as well, other trials and programs have used adjuvants. So, for example, omalizumab, dupilumab, probiotics, and other type of adjuvants have been used to try and achieve a higher rate of desensitization or higher rate of SU from OIT itself.
So thank you, Paxton. Thank you, Sigrid. So in view of the time constraints, so we're running out of time. So I would like to conclude here by thanking both Paxton and Sigrid. We still have some questions, but we hope that we can address that in the next JAAFCA session. So please join us next time. And of course, we'd like to thank Professor Ruby Puwanka for leading us here, for starting this initiative.
Thank you very much, Agnes and Paxton and Sigrid. It was excellent. It was just super. And I think there was a lot to learn, even for us. It was a very nice experience to hear the different perspectives. I really liked the literature review. I really liked Paxton's talk, and I really liked the practical aspects, because I think it's very, very important to have the connect with the patient. The connect with the patient is so important. I think that human touch is lost often. And it's not just in food allergy, it's across allergies. You see children with asthma, with rhinitis, most of the time there is that human connect is lost, and we just prescribe, and then that results in a poor compliance also. So bringing that up, I think Sigrid was great. I'm excited to see the extent of questions here. It clearly shows the success of today's JAAFCA. I sincerely thank Agnes for leading this, and Paxton and Sigrid for working together for making this such a successful JAAFCA. This is our first, and I think what starts well always continues to be excellent. So we're looking forward to this further JAAFCAs. Some of the questions that are here, just for the audience, I'd like to say that we can also try to answer by email, and also we can do it at our next JAAFCA. We will try to meet you and stay in touch with you more often. So to all the audience, a very big thank you from Apaaaci, from myself and my team, both in the leadership as well as my secretariat, and my dear JAAFCA steering committee, led by Agnes. And see you all very soon. Keep safe and stay healthy.
Thank you, everyone.
Bye. Thank you.
Thank you, everyone.